Committee, we thank our distinguished faculty, delegates, and guests for their active participation in this session. We'd like to ask the participants to please note if any unattended delegate kit bag of Dr. Bandari Manisha is there and to provide it to the registration desk if noticed. Thank you.
A very good morning. Next is the prestigious Veerabai J.R. Das Agarwal oration. For this, I would like to invite chairpersons Professor Ananda Krishnan, Professor Sujay Bal, orator Dr. Avinash SUPE to the dais. Say this. I would like to invite Professor Sujay Pal to conduct the oration.
Good morning, all. It's my pleasant duty to introduce Dr. the Veerabai J.R. Das oration. There's an interesting story behind it. During the initial days of Indian Association of Surgical Gastroenterology, the founding secretary, Dr. Aranya, got a generous donation from a local Delhi surgeon who was Dr. Agarwal, and it is as an honor to his contribution to the initial financial assistance given to Indian Association of Surgical Gastroenterology that his mother, Veerabai J.R. Das, J.R. Das, was honored by this oration. And since then, the tradition is that initially, the past president would be giving this oration till 2016, but thereafter, any eminent GI surgeon in our country who has contributed immensely to the science of GI surgery, and you can see the list of orators over the last almost decade and a half, and we are honored and pleased to give this honor to Dr. Avinash SUPE, who you know is a doyen amongst teachers and who will be presenting this Veerabai oration today. I would ask Professor Jaswant, the organizing secretary, to give a brief biodata of the orator, and thereafter, Dr. Avinash, I'll request you to start the oration.
It is my proud privilege to introduce Professor Avinash SUPE. Professor Avinash Nivrithi SUPE, Director of Clinical Governance, PD Hinduja Hospital, Senior Consultant GI Surgeon, Zen Hospital, Mumbai. Dr. Avinash SUPE had an exceptional academic career and has been a distinguished student all through his training phase. SUPE's extensive training includes advanced fellowships at the Memorial Sloan Kettering Cancer Center in New York and Hamburg, and a Master's in Health Professions Education from the University of Illinois, Chicago. Our SUPE continues to blend surgical excellence with systemic quality improvement in field of surgical gastroenterology. He is a professor emeritus at the National Academy of Medical Sciences. He served as a director and dean of medical education and major hospitals under MCGM. He was instrumental in elevating standards across municipal hospitals in Mumbai. He has served as a professor of surgical gastroenterology and medical education at Seth GS Medical College and is rightly appointed the chairman of the GI Surgery Board of the National Board of Examinations. A prolific scholar and educator, Dr. SUPE has authored 10 books, 24 booklets, and published 340 peer-reviewed articles, delivering over 675 presentations worldwide. His research impact is globally recognized with an H index of 37, I index of 82, and over 11,000 citations, earning him a place in Stanford University's list of the world's top 2% scientists in both 2023 and 2024. Throughout his career, he had held key leadership positions including Secretary, Asia Pacific HPV Association, President of the Indian Association of Surgical Gastroenterology, President of the Indian chapter of the International Hepatopancreatic Association. He is the founder director, GSMC Fimer Regional Institute. In the past, he has chaired expert groups under the Medical Council of India and the National Medical Commission. Dr. SUPE has received 73 prestigious awards, including Dr. B.C. Rai Award, Maharashtra Bhushan, Chembur Bhushan, Mumbai Bhushan, and multiple awards from ANBI, MMC, MUHS, and the National Board of Medical Education. He has also delivered named orations, including Colonel Dr. Pandale, Amasi, Dr. G.M. Potke, and APH orations, among others. He is a centurion blood donor, having donated blood over 126 times. Ladies and gentlemen, in recognition of his yeoman service in care provisioning and academics of surgical gastroenterology, the members of IAG has rightly chosen Dr. Avinash N. SUPE for the award of the prestigious Veerabai Jayardas Dr. Agarwal Oration for the year 2025. Dr. SUPE.
Respected Chairman and Dr. Jaswant for that generous introduction. All my colleagues, mentors who are sitting here. Thank you so much for this honor, and I really appreciate being honored by my own society. I'm sure I would like to thank everyone and many of my friends who are there and who have been part of this whole journey of mine. It is usually customary to speak about personal journey in this particular kind of orations. But as I said, my career has been like an open book. I have talked on so many orations and books, so I am not really going to speak on personal journey. So what I'm really going to do today is trying to review our journey of our GI surgery community, which started about 40 years ago. I remember the ISG Con 1985, Dr. B.K. Krishna Rao is here. And I think he remembers in 1985, we had this ISG. And in this particular hotel or similar hotel, we were a group of surgeons that time. Dr. Rangabasham was there, Dr. Manohar Joshi was there, Dr. Mathur was there. And we got extremely frustrated in ISG Con when the surgery had only one session. And we said in the whole 4 days conference, surgeons only have one session. So let's form a new association. And that was the beginning of an ISG. And I remember we had, in 1988, ISG was established in Delhi. The first conference was held in Hyderabad by Dr. Professor Chalapati Rao. And today we have a 35th conference, which is being held in Chennai. So we have come a long way in the last 35 to 40 years. Now the question is, what are the challenges of GI surgery today, after 35 years? How do we look at our own community? Now, GI surgery is a challenging, exciting, and rewarding career. It is the top 3 sought after surgical careers. You know, I think people strive to become GI surgeon today. And if you really see NEET scores, GI surgeons are on the top 3. However, if you really see, we have grown from open to endoscopic, to laparoscopic, to HPB surgery, with increasing challenges and with more technology. And we have been really doing well with endoscopy, robotic, laparoscopy, hybrid, and AWR. So we have really progressed every decade, and we have a challenging kind of a surgery. But emerging careers and practice dilemmas started coming simultaneously with this. The main dilemma was GI surgeon versus surgical oncologist. Who would tackle CA cancer? Who will tackle colonic cancers? Open versus laparoscopic versus robotic. These debates have continued because the technologies started coming up. Colorectal versus HPB versus foregut, system-based surgeries. Transplant and AWR, technique-based specialties started separating out. And lastly, IBDs, ulcerative colitis, we saw a biliary cancer group working, so disease-based. So there was so many kinds of these practice dilemmas started coming, which have started affecting the way patients are. So if you take an example of a rectal carcinoma, open surgeon will do radical AR giving the best clearance. Laparoscopic surgeon will say LR is superior, 3-day stay. Robotic surgeon will say better precision. Medical oncologists are talking today of no surgery. So what happens because of this? Diverse strategies confuse patients. We are really talking about a patient who has anxiety and potential treatment delays. So if you look at AWR, this is also a way specialists choose what they know than what is best for the patient. Today we are coming to an area where people are looking what they want to know rather than what is best for the patient. Now this kind of a problem has occurred in many other specialties or disciplines also. And this is called as a divergent thinking versus convergent thinking. From ideas to question and from facts to answers. Many disciplines have faced these kind of dilemmas. So how do you really try to solve? So Ford and Miller gave this kind of a framework. And he says from personal evaluation, consensus, vicarious evaluations, and idiosyncratic criteria, people started looking at solutions. And what ultimately came out? Consensus, problem service expertise, keeping patient as a focus, shared decision making. So these are the new areas which are coming up, which we all should really start thinking about. So if you look at a multidisciplinary tumor boards, I think yesterday Sudeep took a wonderful session on AI and now on a multidisciplinary board, but such kind of virtual boards and AI solutions are going to be in future, and we should try to see we expand. IASG has already taken a step and we try to do it better. Teams work better and create a disease-specific expertise, and that is something which is also extremely important. So the first question you should really ask, how can I build my professional identity in an era of rapidly expanding knowledge and technology? Today is a time of professional identities. How do you develop? Probably in my generation developed it, which people started on their own, it got developed. But it's time now the new generation should make an effort to develop this professional identity. Now that brings the next question to us is, what is the role of specialist versus super specialist? Now this is a question all of us many times separated from a general surgery specialty and started a new specialty of super specialty. So what is the difference between that? The difference between specialty and super specialty is, let's take this example, simple example. There's a hospital M and hospital N. Both began with similar laparoscopic and GI surgery setups. Both have adequate infrastructure and expert qualified surgeons. Let's go 10 years fast forward. Now 10 years later, Hospital M has developed a reputation of excellence. They are referred the toughest cases. They have a signature approach for hepatic and Whipple's. They are in the top 10 hospitals. Patients travel to seek care and residents compete to train there. Growth occurs through excellence through focused domain. While the other hospital is performing simple cholecystectomies and appendicectomies, busy OTs. Many cases get deferred because they are too stuck. Referrals are sporadic and struggles to attract skilled fellows. Busy but unfocused, outsourcing complexity. Now, it was not the infrastructure, budget, or case volume. Strategic focus on surgical strengths, mastery of complex procedures, transformation of skills into core identity. Now, if you really look, growth does not come from doing more. Growth comes from mastery in a select cases, building your distinct identity. Now, what today we need in India and in GI surgery is developing these professional identities. So, if you really look at surgical skill levels, there are so many competent surgeons. We need expert surgeons. So, we need to really grow beyond that competent surgeons, and that's where people, if you see around the world, the people are really doing this. So, excellence comes from depth of skill and courage to tackle complexity. It's not the numbers that define your practice, it's the concentration of competence you bring to each case. The future of surgical success, if you really see why one center does much better than the other centers, because so you must really try to join centers which build a cross-disciplinary competence. Very few centers could really achieve this in our country. So if you really look at, very few people like Dr. Palnevelli really thought about putting everything specialty much before others thought. So he has now a team for upper GI, HPB, colorectal, and then bring the different technology into that particular team. So I think as disease-specific or a system-specific teams are likely to proliferate more in next few years. Look at the Japanese fellow talked about a biliary cancer team. They are only working day in, day out on biliary cancer teams. So it's time to mentor subspecialties, time to maintain disease-specific, system-specific specialties. So that brings the importance of investing into surgical education today. If you really see, we have to invest, and why it is important. Now, government decided to increase the number of seats. From 2,400 general surgery seats, we have 6,000 general surgery seats today. Sudden rise, without infrastructure rise. And what has it resulted into? If you really look at this growth till 2050, if you really see, we are still going to have a shortage of doctors even in 2050. Because whatever will are going to happen, if you really look, this is a projection, of course, from Lancet based, but if you still have in next 5 years, or we'll have little more number of doctors because we have changed the number of seats, but we'll still have a shortage of doctors. So today in GI surgery, we have 104 DRNB seats, 79 MCH seats, total 183 seats. What about their quality? Quality is a concern with increasing numbers. If you really see, look at this paper, Challenges of Surgical Education in India. It talked about practical skill gaps. It talked about curriculum, except versus execution, and subspecialty training. These are all published papers. These are not, of course, we all feel that way. So there are no standardized guidelines for minimum surgical case numbers. I'm sure all of us try to think about it. Dr. Piyush, I think it was in our GI surgery board, we tried to work on that, but there's still no consensus about it. Unclear work hour limits, inconsistent supervision with quality across programs, and poorly structured didactic teaching. Now, quality, this was a wonderful book which got published in 2019 about advancing surgical education. Quality and accreditation in education and provider to demand-led service. We are going in this demand-led service delivery. So it got a new concept of surgeon to surgeon educator. There's one excellent surgeon who conducts 10,000 surgeries in his career. This is approximate, of course. But if he passes his clinical and surgical wisdom to 20 excellent surgeons and create 20 excellent surgeons, then the benefit to the society will be to the 2,000 patients. But this does not happen. I have seen people grow, become surgical educators, but they do not really pass that kind of a thing, mentorship, to the people. There's a limitation to what really happens. So if you see what is going to happen in next few years, we have to really think about this. There are two major disruptions which have already come. And one was a wired generation. The generation Z which has come behaves differently. It's a wired generation. And I think this was a wonderful book in last year got published called as An Anxious Generation by Jonathan Haidt. He's a mental social worker. And he says that serving across generations from X to Z and now coming of Alpha, they have each his problem is different. The same problem with different solutions. different problems, different solutions. So we have to really start working on our education in a very different way to the Generation Z. You saw what happened in Nepal, what happened in other countries. So we have to be really aware about all this. The second is AI revolution. AI is going to change the whole revolution. AI stands apart because it is taking control of your human cognitive functions. You know, till many moral panics came, but AI has really brought a complete change into the cognitive control. Learning, reasoning, problem solving. If you really see, there is a de-skilling effect of AI. AI bypasses the fundamental process of learning and threatens quality of learning argument. This is a Harvard study. And I think people have to realize. Now, what happens? How do you build a clinical wisdom? How I think we learn from our teachers. A well-organized, internalized knowledge base. We create discrete skills, and then we do repeated application to make a sound judgment, and that's where the clinical wisdom comes from. And we built it over from UG to PG over years. Now, what has happened? AI cannot replace this exercise. You know, AI cannot replace this kind of a clinical wisdom. But there was a very nice paper which came in this 2025, which said, and in educational hierarchy, we say we follow this Miller's pyramid. So it said AI can be replace knows and knows how, but it cannot replace shows and shows how, and does. I think this is something we should try to give to our students, shows how. And I'm thank you to Piyush for publishing our paper in last week on shows how, getting to shows how. You know, we are trying to tell people that it's time we should concentrate on shows how rather than only knows how. So the whole conferences have to shift from knows how to shows how. In fact, if you want to transform your surgical training, you need to improve the skill-based education, integrate simulations in training. Simulations are very important and they need to be really brought up. You know, everybody has to really work today on simulation. Cadaver labs, various kinds of simulations, you know, they are coming up like anything. And I think the ethics comes in a big way, so we have to really do it. Foster collaborative student teams, you know. I think there's a lot of importance of the teams you can really do. Engage private hospital expert. Today what has happened, technology is in the private sector, much more faster than government sector. There's a lot of expertise and knowledge and shows how in the private sector. The government hospitals and private hospitals need to work together to develop an adjunct faculty so that the benefit is given to both students and increase in the surgeon educators from silos to synergy, and that's what we need to do. So we need to bridge these gaps. Whatever gaps in education, we need to really bring it today. So this was a paper which published about 2 days ago. This was by Andrew Grooms. I'm sure all of you have seen Andrew Grooms. He had come in Calcutta, and he is the person who runs the Journal of AI in Surgery. And I think he published a paper with European AP-HPB Foundation, and wonderful paper, and it really says that future HPB surgeons not only trained in traditional and minimal invasive, but also in AI interventions. We want tomorrow's GI surgeons who are AI enabled, because the people would like and they will replace routine surgeons from those who have no AI interventions, and that's going to be the future. We have to accept it. So teaching is not about creating replicas of ourselves. It is about inspiring the next generation to go further than what we could ever do. And this is what we should do. Maybe our generation brought this GI surgery to a particular level. The next generation has to take it through this wired generation and AI revolutions. And unless we do that, we are not going to go progress in next 10 or 20 years. Now, if you form this education, I would like to take you to the challenges and issues of research and innovations which are happening in our country. Now, I personally feel that conventionally, everybody thinks my patient care is first, and I'm sure that is true. We all work for patients. We should do surgeries. We should try to relieve patients' pain. The second comes teaching, because that's your job. You are called as a professor, so you normally do it in government hospitals and medical colleges. And the research comes last. And this is very common. We don't give so much of importance to the academic excellence and research. Now, if you really see, there are a lot of challenges for people also. You know, it's a quality versus quantity. There's a poor publication outcomes, lack of mentorship, inadequate training, infrastructure deficits. You know, many people would say we don't have a basic laboratory, we don't have a time, and ethical concerns about doing these surgeries. Having said that, I just tried to went to PubMed. I went to my librarian, and she's a very good librarian, Vasumati. I think many of you must be knowing. And she searched for me the GI surgery publications from India. Wonderful exercise she really did. And you look at from 1956 to look at 2026, and there are more than 14,000 publications. And if you look at IASG, since IASG came, we had the increase in number of publications, and last few years we are really doing well. But I think we can do much better. There are so many good papers which are there, which I see in this conference, but they do not see the publication. So I think it's time that whatever we present here, whatever scientific discussions we do, many of them, at least 70 to 80% should get published. So busy, why people don't publish? What I called as an activity trap. You know, busy or clinical workload, lack of research environment, no recognition, and who will read my paper? And of course, what I call as an activity trap, you know, if you treat only activity treat patients, but unless you convert into academic excellence, you are not really going to make a benefit. Another impact has happened because of corporatization. You know, I'm very happy GI surgeons today earn a lot of money. I think many of the private people earn a huge amount of money than what we were probably in 70s and 80s we are earning. Today you see the new generation of surgeons earn a lot of money. But at cost of what? At the cost of education and research involvement. You know, I think they get money, they are very happy, they don't want to spend more time on this. They want to spend on time, which is quite fine. I think Dr. Nandi wrote a very nice book. I don't know if you have not read that book, it's worth reading it. And the title of the book is How to Practice Academic Medicine and Publish from Developing Countries. I think it was published during the COVID time, 2021. And what he really talked about was strong institutional culture, protected time for focused work, mentorship and guidance. And of course, if you really go through, he gave a wonderful form. We should shift from publish to publish in frequently high impact journals, because there are now so many journals have come which are fake journals, pseudo journals, where people start publishing and feel they are publishing. It's time we should really publish frequently in a high impact journal, and maybe then only we will not perish. So their key dimensions are scholarly achievements, research and inquiry, contribution to the academic community, critical thinking, and academic integrity and ethical. The whole question today is, how do you preserve your academic integrity in this world of AI? You know, AI has been asking this question. I can do content generation so easily. You know, I was going for one workshop and I saw one person from PGI who created a systematic review in front of me in 2 hours. And he says he had 256 systematic reviews published, and they were all from AI. So now the question is, how do I preserve my academic integrity in this particular era? So research drives academic excellence, but a quality culture ensures the improvement. We need to have that quality culture fostering accountability and alignment. A man asked a gardener why his plants grew so beautifully. And the answer was, the gardener said, I don't force them to grow, I remove what stops them. So I personally feel we as all mentors should really only stop people what comes in their way of growing. You know, so there are various key strategies. I'm not really going to go into that, but I'm sure we can think about it in your own settings, how you can really use this. So we have to change our culture from publish to perish to value and integrity-based research. Now, Indian innovations, I remember Dr. Mathur is here, we started working on this phenol, and then we started creating this. That time getting a sclerotherapy needle was not so easy, so we started creating. And that time innovations, I think 6 months ago I talked about Jugaad and innovations. I'm not going to repeat that. Here is Dr. Palnevelu, who created hydrated cannula. And I personally feel these are the kind of innovations which are now worldwide taking. We need it to more. We do so many often these innovations and Jugaad. We need to publish this so that we keep our legacy of Indian surgeons into the world. So if you really see what are the key takeaways, I have two major takeaways. Mentors do matter. I think whom you work with and whom you guide you matter. I was very lucky to have great mentors like Dr. Blumgart and Dr. Udvadia and Dr. Rangabasham, Dr. Bhalerao, so many of them, and many of them are not here, but some of them are here, and I'm so happy Dr. Anand Krishnan is there, Dr. Mathur is there, both of them have mentored me, Dr. Nandi as well as Dr. Bapat. So I think mentors do matter. Mentors really guide you beyond your thesis and your work. Secondly, another thing which I think over years what I have learned is team collaboration and trust. I think this is something which all of us should work. You know, previously we used to work individually. It's a time now that we should start developing teams. Look at India. Those GI surgical teams which have succeeded have developed teams, focus, professional identities. Those have done well. I think it's good to really think once and stop which teams in India are doing better and what are the reasons they are doing better. You know, I remember President is not here, but when President shifted from one hospital to another hospital for his liver transplant, he shifted with 155 his team members, which included surgeons to nurses to his servants. So I think what matters is a team and trust. So if you really look, what I would like to really think about way ahead and recommend for future directions, I think develop your professional identity. This is one of the most important aspects of anybody's life. Think about it. You know, one of my boss used to always say, Alan Schwartz, who was a psychologist from Chicago, used to always say, Avinash, every 3 years you take a break. Think about, is my career going in the right way? Do I need to really make little side adjustments? I think all of us should really do this. Is my thinking going in that particular way? If it is doing it, it's worth really taking that 1 or 2 days off. Build a portfolio in your system, organ or disease-based specialty. It's time today we should shift from a general specialty like GI surgery to a portfolio. You may do GI surgery, but try to develop your expertise into one of the organ-based or disease-based. Leverage technology to solve complex clinical problems. Focus on developing departments and teams. You know, I think I was very happy, and I personally feel we had nothing to begin with in about 20, 30 years ago, and today we have a successful MCH program, which is coveted by the top 3 centers in India where people really come. And I feel now I have a wonderful team like Chetan, Prabhu and Sharvari who are really managing it with the state-of-the-art technology, and we're doing excellent work. So it's important to bring back and develop these teams and keep a legacy behind. Be a surgeon educator. You know, it's good to be an educator because invest in education and good mentor. Being a teacher helps you to remain updated, upskill yourself. If you are practicing surgeon, many times you don't update yourself. But if you are a teacher and you have to discuss a case with students who are extremely updated, they know all the trials. And if you don't know, you are bound to update yourself. I think this is where you have to upskill yourself. It's always good to create legacy of students. You know, I'm very fortunate to have my students across the world, and they're heading. Many of them are director of programs, many are leading transplant programs. And I feel very happy and proud when my students do better than me and they perform more complex surgeries than me. I think that is a pride I work with, and I feel that has kept me to go on for so many years. Now, if you really see, we did a lot of innovations in education over years. In 2002 or something, when the laparoscopy was not so were all over the world, we started working on laparoscopic workshops, you know, and first laparoscopy national conference in Mumbai, then in suturing and working, but we went to the smaller cities and we picked up surgical teams. And in my own department, we conducted 1 week's laparoscopic courses for them with hands-on training. And that's the reason we could really go across Maharashtra and develop the laparoscopic surgery. We started HPB courses with Jagannath and Shastri, and the first HPB courses we started in 2009 as a NAMES. It was an experiment, but now it is going on for last 16 years very successfully. And we see the quality of HPB surgery, which has improved in India over last 2 decades. It has been an amazing experience. And in fact, now we have a wonderful outreach program in Nepal, Bhutan, Vietnam, and Cambodia, which is led with the help of IHPB. So I think it's important that a center in Nepal, which was not doing anything, now they are doing transplant successful programs. If you go to, I have gone into the small districts of Nepal where we have tried to promote all these surgeries. So I think it's good to do these outreach programs. Lab Unlimited is a good experiment where do 94 centers worldwide, 6,000 participants. On one day, you find you're connecting the whole world with your live surgery. There are senior to junior surgeons, residents working. I think this is a new way of making education much more. You know, I think previously we used to have these 500 people attending, but this can reach to almost 6,000 surgeons with lot of discussions and interactions with moderators, which are senior moderators their place. Practice academic medicine and publish. You know, I always feel you should publish. I think I have a small contribution in academics, but I think what is more important is that when you start publishing all this, you get lot of benefits of this publishing. You know, we try to do thematic publications. It's important to do thematic publications. Don't only publish because you have got a case. Try to think about it and look at the successful people who have done thematic publications. We have many more papers on one only portal hypertension. Similarly, I worked on ergonomics, laparoscopy, gallbladders, and all this. And now I recently have been working on artificial intelligence. This year I could publish 4 PubMed papers only on artificial intelligence and 1 book. So my actually life's mission today is to have an AI literacy and responsible use of AI with ethical use of AI. If you are able to bring this to our community, have a mission, have a passion, so that you can really bring this academics into the practice. Research gives you so much of leeway that it will take you across the world. Only with my academics, I was a full-timer. You know, we don't have so much of money as a full-timer, but with my research and networking, we could have connections across the world, from ministries to ministries, from Ministry of Tokyo guidelines to FAMER in USA. Practically, you can work everywhere, WFME, WHO, you say the organization, and I have worked with that only because of academics. I think if you look to the West or East, whether it's a Steve Jobs versus Ikigai, it is way to do great work is to love what you do. So be passionate, be mission, vacation. Even in practice, commit time to academic growth and lifelong learning. What we repeatedly do, excellence then is not an act, but it's an habit. Enjoy being a GI surgeon. Thank you so much. Thank you.
Thank you, sir, for the great words. And please accept this.